Okay, thank you very much, and good afternoon, or good noon, in fact, 12. And first of all, I want to thank the opportunity of being able to talk and to share experiences, knowledge, and future as well. So thank you very much for having me here. And what I'll do in this 40 minutes is just to summarize what has been going on in that field for, let me see, that's working. Now, so this is the menu that I have made ready for you, and there are 4 parts. First, I will talk about the 2 approaches of this issue, which is hysteria or a proper diagnosis. And the idea has been taken from talking with most of the patients and subjects and colleagues that very often and too often the word hysteria and other names like that has been used to label, to diagnose this condition. And that was so annoying that I decided to tackle the issue for you today. The second part is, just to review the symptoms and the experiences of the EDS, and particularly those related to psychiatry and to psychological aspects. And third, I will give you an update of the psychiatric aspects as such. And finally, I will provide a model in which we will be able to collect all the evidence and to provide a proper treatment for this condition. This slide would be the backbone of the presentation. First, because there are 2 main approaches to this issue. One is this very classical and very unfortunate, I would say, in which sufferers are accused of hysteria, factitious, or simply exaggerated people. And this has created a stigma and generated a lot of discomfort, understandable, of course. The second one is the modern approach, which is based on real psychological and psychiatric studies, which have been carried out, particularly in the last 25 years. Because what we can anticipate is that EDS provides a particular vulnerability to become anxious, and also depressed, but mainly anxious, to be more sensitive to many stimuli, and not only to external but also internal stimuli. And some advantages, if I have time, I will tell you about that as well. So finally, the clue for the whole talk would be that psychological and physical symptoms must be identified, must be respected and treated at the very same and high level. And sometimes I'm very disappointed to see how often this psychological and psychiatric aspect is neglected. There are reasons for that, even cultural. But I hope that after this talk you won't be neglecting this issue anymore. What about hysteria? It's a very important word in psychiatry and the history of psychological mind. But today is a word which has really disappeared from the clinical scenario, because it has a lot of stigma. It's a word and the likes which are very often poorly treated. For instance, is related to faking, to malingering, to simulation, and this even makes the things worse. Therefore, we decided to remove hysteria. 40 years ago, we removed hysteria of our glossaries and our diagnostics. So every time you hear hysteria, you won't be listening to a psychiatric condition. It's not a psychiatric condition anymore. Among other things, because it's a very, let's say, dirty, very common use term, and very, for instance, you see this kind of hysteria is used in a very different manner, so it is not allowed to use it as a diagnostic anymore. But 2 things I want to point to you here at this slide. First, fight the stigma of mental illness. Don't worry about talking about mental illness. Mental things are an everyday life for all of us. Therefore, don't neglect that issue. And the second one is that both, all of you, but also psychiatrists, we deserve to a kind of checkup in our mind. So don't worry, it's not painful. It's something that can be used, and to be psychiatrists, even psychologists, is a very difficult thing. It takes a long time to learn and to be prepared, to be ready. So therefore, we are not head drinkers anymore. When I first became to these meetings, I was really being looked as a head drinker, not a head drinker anymore, despite my size. Well, when we have removed hysteria, where have all hysteria and all psychosomatics gone after these years? And, well, because the real thing is that there are a lot of symptoms like chest pain, fatigue, dizziness, headache, in which one cannot find any clear organic origin. And then when you find this, you are taught in medicine that there are different types of illnesses, acute versus chronic, multiple system versus single system, but one is this organic versus psychological. And this is a mistake. It is not true that it is or organic or psychological, because it may be both. And this borderline between medicine and psychiatry is a difficult thing, because you see, Kellner saw that all of us, all normal and non-normal people, or patient or non-patient, we are suffering or noticing some physical symptoms, almost 80% of the population, with no particular reason, and that's the average. But when you, as a patient, you go a physician with a somatic complaint, look at that, no clear organic cause will be found between 20 and 84%. So that's one of the problems with the medical. Now, another bag for these psychosomatic symptoms is the medical unexplained symptoms, an awful name, by the way, already removed, but has been of use for a lot of times. And these are very common, so these medical unexplained symptoms, and all medical specialties have these examples: lower back pain, premenstrual syndrome, tinnitus, dizziness, headache. All the specialties have this, one of these patients of this area. But the problem is that these are not as very used for patients. As you see here, help me, but well, don't worry, it's a medical unexplained symptoms. So this is very disappointing for patients, but also for doctors. Don't forget about that. Doctors also feel disappointed with these conditions, or they have no idea what's going on, which is very often the case. We put some nice face, but we don't know what is going on, or we feel challenged. Therefore, it's not an easy thing for doctors either. And of course, this happens, and this is well, often I remember that a rheumatologist told me, you know what is the main criteria to diagnose fibromyalgia is a patient when sitting down in front of you, and in 5 minutes he is hating you and you are hating them. And this is what a rheumatologist is very, and well, this has not to be the case, but you understand what I'm telling you. Well, this is the vicious circle. So the patient seeks help, the doctor focuses on organic symptoms, no finding on the investigations. Then the doctor starts looking for psychosocial, then the patient denies and becomes enraged, and then misunderstanding, doctor is irritated, and doctor shopping. This is very often the case. Well, so therefore is a thorny way, this psychosomatic. Well, in some ways, yes, but there's hope. Yes, there is some hope. In fact, those who study the psychosomatic area are really providing a new clues to tackle these areas, but not to say it's organic or psychological anymore. We have to be able to combine it to know about two things, and this is particularly important for EDS. So, all organic is all psychological? No. be able, please, to understand both worlds. Unfortunately, the psychiatric classification, this is the last one, still keeps psychiatry in the mental part and not the organic part. This in the right-hand side, you see the new provided DSM-5 diagnosis, which they only tackle the, let's say, the behavioral and the psychological part of it, which is, in my opinion, not enough. Now, the second part is what is really happening with EDS. And then to do that, I have taken advantage of this worldwide survey. And well, I couldn't have any better slide. We have, by the way, some of you might have these slides of this survey. I would be very grateful if somebody would provide me this worldwide survey. So I did my best to get the information. As you can see, pain, central nervous system, this funny dysautonomia, headaches, a lot of fatigue, sleep disturbances, digestive symptoms, lightheadedness. So a lot of these symptoms. Then you remind this set of symptoms something. Yes, these medical and Misplayed symptoms. So unfortunately, you are really on the right target of this difficult and gray area of the psychosomatics. What if we ask patients about depression and anxiety, apart from our studies? And you see, again, that a lot of patients report a great deal of anxiety. This is a very recent publication. 74% scored high on anxiety and 22% on depression. High figures, much higher than in other medical conditions. Therefore, you have to take into account this. So this is real thing, this is real life for EDS. Another question has to do with the experience of EDS. Has a present or past doctor made any of these statements about your condition? And look at them. It's all in your head. There's nothing wrong with you. You shouldn't be that much pain. You worry too much. Might be true. Sometimes you worry too much, but you have to be told in a very gentle manner how to handle this, not to be accused of that as a reason to be so complained. So you should be happy. We can't find anything wrong. That's really, and even worse, you are looking for attention. This is a very classical thing, not very helpful. And therefore, most of the respondents say that this was invalid or negative comments. This reflects really the poor understanding. There is one question very important to this talk, which is that 97% of the respondents said that they labeled with a condition, a psychological condition to explain. That might be present, but not as a cause. Be careful with the cause. Clinicians know that there are many causes for one effect. No, it's not a bacteria and an effect. It's never like that. It's very seldom the case. In medicine, you have a cause and you have an effect in many causes. So distrust when there's just one cause is very seldom the case. But geneticists tend to think that there's one cause and one effect. A real life is not like that. And this is one of the discussions we have with our colleagues geneticists. So in terms of our field, anxiety and Ehlers-Danlos, is one producing the other or the other one? Either way, they have plenty of things that produces them, but we have to take into account they just coincide in the same patient. You have to tackle both at the same time. The third part is the update of the psychiatric aspects. And let me stress that never only psychiatry, never in that case. Then there is a kind of summary of all the papers published in the area: anxiety, mainly depression, personality disorders, psychosis, eating disorders is very, very prevalent, neurodevelopment disorders, particularly ADHD, but also autism, a lot of conditions now are being attracted by the field, and they are full of new papers. This was published in the American Journal of Medical Genetics in our group. And here you can see that Professor Graham and Amonet and Professor Bravo and Casturi were in Paris discussing that. And again, I want to be very grateful to this meeting because I take advantage. I learned quite a lot of not only the colleagues but of you as well. The evidence is very clear. Sometimes there is one evidence. What the hell of evidence? We have plenty of evidence that the psychological part of Ehlers-Danlos is there. This is the modern meta-analysis. And to summarize, just concerning anxiety, among our anxiety patients, the evidence says that between 50 and 70% of anxiety patients have EDS. I mean, at least the Byton criteria, more than 4. And if you look at the other part, among patients with EDS, about between 1/3 and half of them will suffer from any anxiety symptom in some part in their life. But don't forget that both conditions, anxiety and EDS, very often go unnoticed and are invisible, which makes things a bit worse. Now, as a risk factor, we studied in a follow-up paper, we show that being hypermobile provides you more risk of becoming anxious sooner or later in your life. In fact, you have a risk of 22 times more, and in that sample, 41% of patients or subjects become anxious after these 15 years. This is our more recent paper about the same association in elderly, and now we are preparing the same in children. Well, what we know after these 30 years? Well, we have plenty of activity and, well, all we can do in our clinical practice, but also we have some clinical with patients and non-clinical samples, neuroimaging, schizophrenia, bipolar, a lot. We are studying now in borderlines, of course, the autonomic nervous system, these new treatments, sophrology, relaxation, we are studying mainly sophrology, and even animals, we are studying the same. Are dogs with hypermobility more anxious? Then we are about to publish a paper on that, by the way. And well, finally, the fourth part of my presentation is to provide you a new model to collect all this knowledge, all the expression of symptoms and all the ways to understand the situation. And the neurocognitive phenotype, which I have been able to provide with my colleagues, is around the nuclei of anxiety and hypermobility, which have to be properly diagnosed. By the way, we have 3 areas which we have to know and assess 3 somatic dimensions. One is the somatic conditions, somatic signs, and somatosensory symptoms. And then 2 behavioral or psychopathological issues. I shall review briefly them for you here. First, the somatic conditions. So this is the model, and I will go over all of them. Well, of course, you know all of them. Irritable bowel, dysfunctional esophagus, POTS, multiple chemical sensitivity. Most of these conditions are very often seen in that case. Second is the somatic signs, not the same condition that a sign. For instance, we studied the asthenic somatotype being more thinner, the dark blue, so a lot of things which you will identify among the EDS descriptions. But this is also done for psychiatrists. We don't know nothing about this, and we ask them to learn how to assess all these things. Then the sensory. EDS very often is, they have plenty of sensitivity. Sensory processing is very active. More olfactory, we have done a lot of studies on that, visual stimuli, dizziness. So EDS provides you a special way to detect information about your environment and about yourself. And this is from the very early life. Therefore, you have to, when you, as a doctor, when you see a patient with this patient has been feeling a lot of things that you cannot imagine for years. That's why it's very important to take this into account. Pain, for instance, is the most often complaint. But what about these intolerances? Drugs. They tolerate particularly bad antidepressants. You have to be very careful in giving antidepressants because they find difficult to tolerate them. Now, psychopathology. Of course, this increased exteroception have been doing work on wind, for instance, and the detection of the body, depersonalization. They have failed a lot of difficulties in grief. Loss for them is very difficult, and some of you will identify this. Of course, the anticipatory anxiety, but they have a very high positive confrontation. They are very good in fighting, very good. They are prepared to war, actually. But when you are in the war, not anticipating what you are fighting. Of course, the typical fears that everybody has, the agoraphobia, which is in the nuclei, and other fears and phobias. All of these have to be asked carefully, not accusing them, accusing subjects of suffering this. The behavioral area is interesting because they move in the extremes. So they can fight, but at the same time, flight. They may be invasive one day, another one may be avoidant. So they tend to move in the extremes. They are very dedicated to oneself, like egotistic, but at the same time can be very dedicated to others. They can have a lot of over-control, religious, etc., and be trapped in some addiction. So this being very dependent, at the same time very isolated. Then the patient asks you, well, I'm dependent, I'm isolated. Well, both ways, because the difficult thing is how to balance between these two extremes that everybody has. And the problem with this condition is that you tend to go to these extremes. So, in other way, they move from one extreme to the other, and they find difficult. Or you are fight or you flight. What are the mechanisms behind this relationship? After all these years, what I can tell you is that between this EDS and these conditions, first we have plenty of clinical evidence. Plenty. After 25 years, I have plenty of data on that, and I have epidemiological evidence and the clinical genetics. So patients and families go quite often together. But we also have a lot of information about the proprioception, worse proprioception, but increased in interoception, so perception of the body, and exteroception. So places, closed places, lack of light, or just the opposite. Not easy. Changing house, very difficult for them. And of course, the dysautonomia has been tackled in another meeting. And of course, we have some evidence for neuroimaging, but I pray if anybody of you want to study this or have ways to improve, because this is an area that has to be studied. Not just the structural, but how the brain reacts to stimuli. We have published a bit, but a lot of research is needed on this area. And interestingly, they are either warriors or warriors. They are both. You can be very warrior and in front of a trip, in front of an exam, but at the same time you will be very good in being a true warrior. The two things might be compatible. That's a very important thing to understand, that might be even some advantage. Well, to summarize, well, going back to this survey, see what statements reflect your feelings about being diagnosed with EDS. And look at I was relieved to get the diagnosis and was open to accepting diagnosis. This was overwhelmingly the most important part of their answers. Therefore, it's very important for a patient, for a family, for a parent who have a kid with this, to be told about all these things, not just about the physical and the mechanical things, but also how to handle all these things and how to take advantage of the extremes of the behavioral part, and not only from the negative part of it, because these things quite likely are very able to be handled by the person in health, and this is very important to teach. And therefore, this is the model I offer to classify, to understand all these features. I've written a book on that in Spanish, but still not in English, in which I summarize the whole thing. And as I was telling you, somebody here before, this book has been written with my hand, but with the ink of the patients. Some of them quite likely might be here. Finally, this parable of the blind man and an elephant originated in the ancient in the Indian subcontinent. You can find this sculpture all over the place in India. It's 6 blind wise men identifying, examining an elephant in order to describe it to the king. And this blind finds this is a wall, this is a rope, this is a tree, this is a fan, this is a snake, this is a spear. So this what isolated wise men, blind men, can identify on their own. But the king can only visualize an elephant by integrating all these descriptions. This is the model I have used to provide this neuroconnective phenotype by which you perhaps may be able to give clue to understand to sufferers these things. So therefore, to conclude, first, take a modern approach, not hysteria and the like. Avoid this pejorative and these useless names. Second, it's very important to listen and to collect what is going on. I'm really disappointed when I see these posters of EDS without any description at all of anxiety, worry, fear, which is everyday life. I worry about that. Why not? It's a stigma, then remove the stigma. And you also can help on that. Third, update on the psychiatric aspects. You have plenty of information, plenty of data on that. Very serious, very well published. And therefore it's very important to take advantage of the knowledge, very serious. And finally, we need new models. Mine is one of them. It's not definite, but at least provides you some boxes to understand, to classify, to learn, to acknowledge, to have some insight on this difficult condition. And finally, this is the final one, which I want to, well, this is funny translation. Here it used to put here Barcelona and zebras, but some translator has just provided a surprise here, but well, at least this has been properly conserved. Thank you very much. Yes, if you have questions, I will be happy to answer them. Here. There is a micro. No. Okay. Here it is. Yes. Yeah. The question is if there is a difference between the different types of IDS in relation to anxiety. Well, as far the main information has been done in the EDS type 3, so let's say the one which is the so-called benign. Although I have seen some patients with other types of EDS which also suffer from anxiety. So there is not much information, but quite likely they share these things. And one can say, well, it's so severe, the condition, that is, well, it's understandable that one is anxious because of the severity of the diagnosis. Well, this is true, but perhaps on top of that, you have some particular vulnerability that has to be dealt with, even more, because the severity is not just the vascular, but the anxiety that goes with it.
So I'm being treated for mast cell activation disorder, and I take cromolyn. And right around the time when my cromolin's wearing off and I need my next dose is when my anxiety gets the worst. Have you investigated that link with mast cell activation disorder and anxiety?
So I can understand. Can you put your micro?
So I'm being treated for mast cell activation disorder, and about the time when my cromolyn wears off is when my anxiety is the worst. Have you looked at the link with mast cell activation disorder and anxiety?
Yes, one of the lines that we are going to start with with our colleagues, because in fact when we assess, we have an anxiety unit in Barcelona, and we have collected a lot of physical conditions, but particularly this mast cell that some patients are suffering from, we have not collected it systematically, and we are going to, because it may provide some understanding not only of some of the physiopathology, but also for the treatment. And going back to the psychopharmacology, the very first drugs that were used in psychiatry was antihistaminics. So therefore, we better learn about that. So it remains to be done, and I hope that we will be able to provide some data next year. Thank you.
On an earlier slide, you mentioned eating disorders, and then next to it was eating chocolate.
Yeah.
And I'm actually ashamed of how much chocolate I can put away sometimes. Dark chocolate, but I wondered why that was there.
Yeah, that's a very good question. Again, it's one of the things that I learned from you, by the way. And I said that some patients just take advantage of dark chocolate. And I did crossed over study, giving chocolate 1 week and 1 week alternative. And some of the patients really improve during the week. They take the chocolate, the dark chocolate. So it's not just a question of they are very good at tasting, but they feel some relief on that. And ever since I did a study when I was young, and now a lot of patients just declare that they use chocolate as a kind, not just as a pleasure, but as a treatment. And we published a letter in the Journal of Nervous and Mental Disease just telling this, that these patients sometimes take advantage of this. So we better pay attention to, and even I use that strategy when patients cannot tolerate antidepressants. I give them tryptophan together with chocolate, dark chocolate, and they improve. So therefore, thank you for teaching us this observation.
Do you find, are there any differences in psychiatric outcomes in depression, anxiety, coping in general, if the diagnosis of EDS was made later as an early adult or later in adulthood versus people that were diagnosed as teenagers and haven't really been able to acquire a profession or be more functional out in society?
So if I understand it, if the diagnosis of anxiety is different according to the time when the diagnosis of EDS was done. Is that? Well, we have all of the, all my patients I see in my office as a psychiatrist, I assess all of them, and most of them have no idea what is EDS, most of them. And when they become familiar with that, then they first take advantage of the physical treatment, which they never have thought of before, and therefore they really take advantage of that. And therefore what I would say is that in general EDS is not well known, but when you introduce that variable in the diagnosis, the psychiatric part also is improved. But there are not many differences depending on the moment, as far as I can see. Most of the subjects, they agree, not easily, because one of the things that I said here, the fear of medications, in this light you see, is very often the case. So one of the very difficult things that I'm not use of medication, and then you have to spend 10, 20, 50, 30 minutes to tell them that if you handle properly the medication, you will improve. But this is one of the problems that you have to take into account. Most of the patients, first of all, are fearful of taking medication. This is the other side of the coin.
I know that there's a lot of the symptoms of EDS, and like, for example, the brain fog can sort of mimic ADD, or also sensory processing. Can you speak a little bit about the treatment for the brain fog using stimulants, even when it's not necessarily a clinical ADHD?
Yes. Well, when you have an ADHD subject, which, by the way, is very comorbid with anxiety, you have to learn how to handle this, because if you just give stimulants to anxious patients, they become worse. But in my experience, and the published data is that you can combine, if you first started with antidepressants and then slowly increasing dosage, then you can combine again very slowly to give stimulants. But either way, alone would be really probably something that won't work, because the intolerance is very high. So therefore you have to be very careful in diagnosing, and to do that it's very important to include the patient in the decision-making process. And this is very, very easy to do if you take your time. I mean, the main important thing that a doctor do is to provide a clue for the patient really directing their goals. Doctors are really helping patients, but the patient is the one who has the illness, who has the symptoms, and has to really to be the leader of himself. And this takes some time, but this is really what in that case is very important, because some patients of this are reluctant to take drugs, and they are refused, or they have no insight on that. But it's your job to teach them how to handle this, because they are their lives. It's not the kingdom of the doctor. No, it's just the opposite. It's the patient's kingdom, and we are going to help on that.
What are some treatment modalities that you found work with the extremes of the fight or flight response, and just to help calm that cycle that you were talking about, this very extremes of fight or flight?
Well, for instance, anxiety or depression processes are going on, it's very interesting to provide medication, because particularly antidepressants help the patient to have these milliseconds not to go to one side or the other. This from the neurobiological point of view. But again, if you just do that with medication, you are losing track, because you have to be, so the psychotherapy in that case, help the patient to identify when he's screaming or is evasive, when he's invading, for the typical shy person, or is extremely silent, or screams. Well, if you, with medication, provide some more ability not to go automatically to the extremes, but you teach how to identify the states, how to govern themselves, these two extremes, and to take advantage of the whole range in the middle of the two extremes. This is the best way. So therefore, it's very interesting to combine drug treatment and psychotherapy. And doing that, another word of this physical treatment. One of the beauties of this condition is that the physical treatment is much more helpful when you have this condition than other patients, other psychiatric patients that have no EDS, because physical treatment is really very, very helpful. Might be a bit addictive, so you practice every day, and one day you don't. That day you might be suffering a bit, but this is one of the things that I try to study and to advise, to include the physical treatment on that.
Over here. How do you balance the cycle where you're being prescribed medications that may amplify depressive or sedating effects, and you also have anxiety and depression independent of the side effects of medications that you're taking for other aspects of your Ehlers-Danlos? And is there a difference between male and female physiology in, are certain classes of drugs better for female physiology versus male physiology?
Well, concerning the gender differences, there have been some attempts to demonstrate that some antidepressants are better for women than for men, but so far nothing very consistent has been found. What really is important that to know that antidepressants, which are very powerful drugs, by the way, very soon you will never listen again antidepressants or anxiolytics, because now the names because why you are giving antidepressants to a person who is anxious? Well, then this particular nomenclature will disappear, and then we will talk about SSRIs or the mechanism, because it can be misleading to use antidepressants. But having said that, antidepressants, this group, are the drugs much useful, the more useful for anxiety. Because in 2 weeks' time, not in the beginning, because if you give antidepressants, the first week is awful. You have to tell the patients, in the first week you might be worse, or at least you give very, very slow dose and get increasing. But the effect will be after 3 weeks of the proper dosage. And this might take 5 or 6 or even 7 weeks. So this is very important to acknowledge that the first reaction is very, very different than the one that is going to happen in 4 or 5 weeks' time. And therefore, the first part is like if you take a marijuana, the first day you would be mad, but after 3 weeks you become, well, let's say, used to it. But I can tell you that marijuana is providing me a lot of patients, because they have one puffing and they become panicky and then they come to my bed. But it's similar to antidepressants, by the way. So therefore, I advise to properly use antidepressant anxiolytics, and at the long run, they are very, very useful.
Okay.